The following podcast is part of a certified educational activity titled Rewriting the Rules for Early Cancer Screening, Case-Based Insight on Primary Care Principles for Using Blood-Based Screening Techniques. Access the entire activity and complete the post-test at peerview.com/KXM860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. John Russell from the Sidney Kimmel Medical College at Thomas Jefferson University. Welcome to this educational activity on the potential of emerging blood-based multi-cancer screening test. I'd like to introduce my colleague, Dr. Minetta Liu from the Mayo Clinic in Rochester, Minnesota. During this program, I'll be your guide through several case scenarios designed to illustrate how novel cancer screening strategies can inform primary care practices and potentially change how we detect cancers. Before we start our case discussion, I'd like to ask Dr. Liu to discuss several unmet needs in the early detection of cancer and the evidence behind several blood-based cancer screening technologies.
Thanks, John. Many cancers are often detected at later stages, but early diagnosis can dramatically improve cancer survival. Many cancers, including breast, colorectal, and lung cancers, are detected simultaneously with metastatic disease. Looking at 5-year cancer-specific survival for all cancers when diagnosed early, it's on the order of 89%. That decreases to 21% when those same malignancies are diagnosed at late. If we focus specifically on lung cancer, 5-year cancer-specific survival rates are 56% for localized disease and only 5% for those individuals diagnosed with metastatic disease at presentation. Gratefully, we have some cancer screening tests to facilitate early detection. But early cancer detection offers an opportunity to diagnose malignancies at a time when outcomes may be improved. But these screening paradigms are limited to a handful of malignancies: breast, cervical, prostate, lung, and colorectal cancer. We also have to recognize that adherence and access to these assays or studies is low as well. Imagine a world where we have a multi-cancer blood-based cell-free DNA or cfDNA test, that a single blood sample could be collected at the point of care and subjected to an assay designed to detect many lethal cancers, including unscreened cancers, again, from that single blood test. And in that same blood test, there would also be a report of the tissue of origin to appropriately direct the diagnostic workup. With high specificity on the order of 99% or above, we could limit false positives and unnecessary workups. And very importantly, a test like this would be intended to be used alongside and not in place of guideline-recommended screening. That world isn't so far away. There are some multi-cancer screening tools actively being evaluated in clinical trials: Gallery, CancerSeek, and Panseer. Let's talk about them in a little bit more detail. The Thrive CancerSeek assay involves a logistic regression algorithm that accounts for mutation data and protein biomarker concentrations. It includes 16 genes, as well as 18 protein biomarkers, all associated with known malignancies. With initial assay development and average performance, where sensitivity of 62% was achieved at over 99% specificity for the malignancies evaluated. Importantly, they excluded stage 4 disease. If you look at those cancers broken down by stage 1, 2, and 3, the proportion detected increases with higher stage, which is reflective of the known associations between cell-free DNA shedding and tumor burden. Interestingly, if we break down by tumor type, there's a variability in the proportion of cancers that are detected by CancerSeek. Ovary, liver, stomach, pancreas, esophagus, colorectum, lung, and breast in descending order. The initial version of the CancerSeek assay also reported a tissue of origin, and you can see the predictions in the bar graph on your right. They range from colorectal to liver, 100% to 63%, again, variability by disease type. The DETECT-A study was the first study to turn around results using CancerSeek. This involved 10,000 women ages 65 to 75 with no history of cancer. These women underwent a 4-step testing process. There was a baseline test drawn, and if that baseline test scored positive if any of the protein or DNA analytes were above the preset threshold. If the baseline test was positive, there was a reflex confirmation test, which scored positive if clonal hematopoiesis of indeterminate potential was excluded and if the identical analyte picked up in the baseline test was seen again. For those individuals with the positive confirmation test, there was reflex imaging, generally a diagnostic PET-CT scan, and this was to provide orthogonal evidence of cancer and localize the signal if it was present. The results were returned to the provider and the patients, and further evaluation was performed as per the standard of care. Of the 10,000 women recruited, 96 were diagnosed with cancer. You can see the breakdown here. The blue represents the proportion of cancers first detected by blood testing, the green, the proportion of cancers detected by standard of care screening, and the gray, proportion of cancers first detected by other means. Importantly, safety was a huge feature of the DETECT-A study. Invasive procedures were performed in 22 participants with a positive blood test and an abnormality on PET-CT, but no diagnosis of cancer. The majority of these procedures were gratefully minimally invasive procedures. 3 surgical interventions were performed involving the appendix, ovary, and rectum, colorectum. In terms of test performance, let's focus on the second column here, the blood test, where there is both the initial blood test as well as the confirmation. Positive predictive value was on the order of 19.4%. Using some form of imaging, if it was specifically PET scan plus the blood test, that increased to 28.3%, and any form of imaging, it increased to 40.6%. Looking at sensitivity, with all included cancer types, focusing on standard of care screening or those without screening paradigms, it essentially ranged anywhere from 27 to 33%. Importantly, this was not immediate turnaround time of test results. The first blood draw to the second blood draw, if a second blood draw was performed, there was a gap of anywhere from about 5 to 5.5 months maximum. And if the second blood draw was positive, there was a gap again of about 3 months before a PET-CT scan was performed. And this was due to all of the careful safety features. But during those intervals of time, some of these patients ended up getting diagnosed with cancer without the blood draw or without the PET scan. The Grail Gallery assay was born from the Circulating Cell-Free Genome Atlas, or CCGA study, which included 3 pre-specified sub-studies assessing participants with and without cancer. 15,254 participants were recruited, 44% non-cancer and 56% cancer, representing over 50 cancer types as defined by the AJCC Cancer Staging Manual. The first sub-study involved a discovery analysis of 3 independent assays: whole genome sequencing, targeted sequencing, including a 507 gene panel, and whole genome bisulfite sequencing. Importantly, white blood cell-derived germline DNA was subjected to whole genome sequencing and targeted sequencing to reconcile somatic versus germline mutations. Sub-study 1 led to the conclusion that whole genome methylation should move forward for further evaluation. And that was the subject of sub-study 2, which then led to the targeted methylation assay that was reported last year. Sub-study 3 is further validation of that targeted methylation assay and is currently ongoing. The CCGA discovery phase was completed in 2018. And again, targeted methylation was selected for further assay development, including training and internal cross-validation. This is development of the targeted methylation panel. A large database of methylation patterns was developed from whole genome bisulfite sequencing of blood and tissue specimens from CCGA, as well as tumor specimens acquired commercially. Again, the whole genome bisulfite sequencing of these specimens was performed. An examination at the fragment level led to identification of signatures reflective of cancer, as well as tissue of origin. And the specific tissue of origin targets are listed on the right. In CCGA2, looking at specificity in both the training set and the validation set, it's on the order of 99.8% and 99.3%. Focusing on sensitivity for the pre-specified cancer types with the highest mortality, as well as all cancer types, again, over 50 different cancer types represented, and breaking them down by stage. Here we include stage 4 cancers, the training sets represented in the red circles, the validation set in the green circles, and you can see again that there is some variability by stage, although there are stage 1 and 2 cancers that are identified. Tissue of origin is reported as part of the Gallery test. Looking at the pre-specified cancer types as well as all cancer types, tissue of origin accuracy was very good, irrespective of clinical stage of diagnosis. 96% of samples were assigned a tissue of origin, and 93% of those calls were correct. We'll turn to the Pan-SEER assay in the Taiju longitudinal study. Unlike the CancerSeq assay and the Gallery assay, which were initially evaluated in patients who were healthy and then ultimately diagnosed with cancer or not cancer, the Taiju study included 2 different arms. One was a prospective collection from 2007 to 2014 from patients who had cancer at the time of the blood sample collection. On the other end, again, from those same years, 2007 to 2014, were samples collected from healthy individuals, some of whom ultimately diagnosed cancer and some who did not. And so this represents blood samples collected from non-cancer patients initially, some of whom remained healthy, and then some who were ultimately diagnosed. This afforded an opportunity to look at potential lead time. And looking at the different years, 0 to 1, 1 to 2, 2 to 3, and 3 to 4, although the number of samples is not huge, there was demonstration of non-invasive early detection of cancer 4 years before a conventional diagnosis. So early detection of cancer can be performed through blood with very high specificity and reasonable sensitivity with these very early assays. John, I'll turn it back to you. Thank you.
Thank you so much, Dr. Liu. I think it's important for our audience to keep the evidence you presented in mind as we'll explore some scenarios designed to illustrate the primary care experience with current screening models and how multi-cancer blood-based screening will potentially change our practice in the future. So let's get started by introducing 2 patients, both of whom present with symptoms that many of us see very frequently. So our first case is Robert, who is a male patient who comes to see me with epigastric pain. He's a never smoker, and he comes to the office for a scheduled evaluation complaining of some epigastric pain. On review of systems, he's noted a weight loss of 10 pounds over the last month. He has a history of type 2 diabetes, pretty well controlled, with an A1C of 6.8. He's obese. He has some renal disease from his diabetes that presents itself with some microalbuminuria. He's otherwise healthy. His epigastric pain has not affected his ability to work or perform his daily activities. And my second case is Ellen, a woman with a family history of cancer. Ellen's a 65-year-old woman, and she presents to the office for a scheduled evaluation. She has a BMI of 30. She's a former smoker with the 15-year PAC history. She took some hormone replacement therapy after menopause, and she reports some occasional abdominal discomfort. During the exam, she notes that her aunt and sister have both been diagnosed with breast cancer in the past. So you've chosen to explore a scenario where we continue the evaluation for Robert, who is our 56-year-old man with epigastric pain. So let's take a look at how we might have proceeded with the clinical assessment of this patient who has some vague but not particularly threatening symptoms. So to recap, Robert is presented with epigastric pain and 10 pounds of weight loss over a month-long period. He's been taking a lot of ibuprofen for some pain that he's had. The pain is not necessarily related to meals. Despite some challenges, including obesity, diabetes of an A1C of 6.8, and microalbuminuria, Robert's epigastric pain has not interfered with his daily routine. During his clinic visit, you recommended PPI and acetaminophen and avoiding the NSAIDs. Subsequently, Robert reports that this has helped address the pain he was experiencing as he follows up with you in the patient portal. So Robert sees you 3 months later for a telehealth visit. Certainly during pandemic, we're doing a lot more telehealth visits. So he decides to safely visit you via telehealth. Overall, he says his epigastric pain has been better with the PPI. His bowels have been a bit looser. His sugar's been a lot worse, but there's really been no change to his diabetes medicines or big changes in his diet. You had gotten some blood work before the telehealth visit, and his A1C is now 9.3. So you decide to recommend better adherence to diet and the telehealth visit with the diabetic nurse educator and dietitian to maybe get him back on course. Pandemic, people have been eating worse, not exercising. So you continue your evaluation to the present day. And although your intervention appears to have addressed Robert's epigastric pain, he comes and sees you in the office 6 months later, and he's lost 15 more pounds of weight. He complains of some nausea and some pruritus. He's noticed that his eyes have been more yellow, and people at work have commented that he doesn't look well. He has labs that show a bilirubin of 16 amongst other liver abnormalities. And that's something when we see in primary care, that person who has painless jaundice certainly is a kind of scary array of signs and symptoms. You order a CT of his abdomen that shows a suspicious mass and liver lesions in the head of his pancreas. Together with the other symptoms, this prompts you to refer Robert to an oncologist. And after a multidisciplinary evaluation and workup, he has a biopsy that confirms a stage 4 metastatic adenocarcinoma with the gene profiling of the tumor tissue recommended. So pancreatic cancer offers the lowest survival rates of all cancers. And I think in primary care, I think this is the scenario that is often the most tragic for us. Our overall 5-year survival rate is about 10%. The median age of diagnosis is 70 years of age. And the majority of the patients who present to see us have advanced disease. For 2021, there's estimated to be over 60,000 cases in the United States. When we look at 5-year survival by stage at diagnosis in the United States, the 5-year survival for localized disease is at 39%, regional disease is at 13%, and disease with distant metastases only has a 3% 5-year survival rate. So what are some of the risk factors for pancreatic cancer? Well, cigarette smokers have about 2 times the risk of pancreatic cancer as never smokers. So yet another cancer that is impacted by cigarette smoke. The use of smokeless tobacco, type 2 diabetes, excess body weight, a family history of pancreatic cancer, a patient who has chronic pancreatitis, heavy alcohol consumption may increase the risk. And there certainly are genetic syndromes like Lynch syndromes and other genetic syndromes, including BRCA1 and BRCA2 mutation carriers. So some of the symptoms to watch for: weight loss, abdominal discomfort, the sudden onset of development of type 2 diabetes, jaundice, yellowing of the skin and eyes, and it can facilitate an earlier diagnosis. Severe abdominal pain, nausea, and vomiting may signal advanced disease. But sadly, the symptoms usually do not appear until the disease is advanced and can include all those symptoms. Currently, there is no screening protocol for pancreatic cancer, although it is the 3rd most common cancer causing death in the United States. So we've talked about screening, and let's look at what are some of the basic principles that we should think about in primary care about screening. And this dates back to a paper by Wilson in 1968 for the World Health Organization. And let's see how this relates to Robert's disorder. Well, the condition should be an important health problem. Certainly pancreatic cancer is an important health problem. The natural history of the condition, including development from latent to declared disease, should be adequately understood. So certainly I think we understand that if pancreatic cancer is found early, it has a better prognosis. There should be a recognizable latent or early symptomatic stage. Well, we talked about the symptoms often being later, so perhaps finding it in that recognizable latent stage would save a lot of lives. There should be a suitable test or examination. As of right now, we do not have that. The test should be acceptable to the population. So Dr. Liu talked about a blood test. Certainly blood tests are very acceptable to our patients. There should be an agreed policy on who to treat as patients. There should be an acceptable treatment of patients with recognized disease. And certainly we know how to approach pancreatic cancer, but sadly we're also often approaching it as a late stage disease. Facilities for diagnosis and treatment should be available. And certainly the treatment of pancreatic cancer would be available anywhere in the United States. The cost of case finding, including diagnosis and treatment of patients diagnosed, should be economically balanced in relation to possible expenditure on medical care as whole. And case finding should be a continuing process and not a once and for all project. So certainly as we think about cancer screening, this is an ongoing issue that we keep reinventing. And we change as the age and how we screen for many cancers. So now you've chosen to view a future scenario in order to explore how primary care practices might change should multi-cancer blood-based screening tests become available for use in everyday practice. So let's see how you might further evaluate Robert using blood-based cancer screening. So Robert is presented with epigastric pain and 10 pounds of weight loss occurring over a month-long period. Despite some challenges, Robert has diabetes, renal insufficiency, some microalbuminuria, but his epigastric pain has not interfered with his daily routine. During his clinic visit and after a discussion with Robert, you discuss cfDNA blood-based screening to gather additional information in the setting of acute weight loss. And I think one of the things to think about weight loss is sometimes we don't recognize weight loss in our patients who have obesity. During the visit, Robert asks if the test is necessary and what is involved. So you say it's a blood test drawn at the lab, can look for cancer. If it's positive, it can point to a most likely cancer source. Does not replace the screening we currently do for 5 cancers. So certainly would not have him forego his colonoscopy. But it can be helpful in screening for cancers that previously weren't screened for and can lead to earlier detection that may be associated with better outcomes. So what are some of those cancers? Well, with Robert's symptoms, you might think of a pancreatic cancer. You might think of a gastric cancer. You might think of an esophageal cancer. All are cancers that we do not screen for here in the United States. Blood plasma is taken, and subsequently, screening is positive, suggesting the presence of a pancreatic cancer. So you refer Robert to an oncologist. An initial CT scan does show a mass at the head of the pancreas near the bile duct. Subsequently, a multidisciplinary evaluation is followed by additional imaging and testing. Surgery is recommended for his stage 2A T3N0M0 disease. So looking at some of the blood-based cancer screening that we heard about, so the sensitivity overall for pancreatic cancer, as pancreatic cancer becomes more advanced, the sensitivity of the test becomes greater. So the sensitivity starts out at about 63% if you look at stage 1 disease and goes up closer to 100% at stage 4 disease, but certainly by stage 4 disease is not where we want to try to discover our pancreatic cancers. And looking at validation of the cancer types, there is a 99% validation of this. So if it's pointing towards the pancreas, we can feel very confident in sending Robert to an oncologist, a surgeon who might deal with pancreatic cancer versus all these other cancers. And I mentioned gastric cancer, I mentioned esophageal cancer. So although not currently FDA approved, the case illustrates the potential value of cfDNA screening in our patients who have vague symptoms, especially those that don't refer to a specific organ. When you think about weight loss in the elderly, it's most often not a malignancy, but often our patients are very concerned about weight loss in the elderly, our patients and their families. And certainly this might be something to reassure some families when the only symptom that we're seeing in their elderly family member is weight loss. It doesn't require imaging like CT scans. There's an impact of radiation exposure, exposure to contrast, and certainly in primary care, dealing with having to get things prior authorized. There's much easier acceptance for patients and completion of blood tests instead of imaging tests. We will need to determine if to screen, who to screen, when to screen, how often to screen, but certainly this is an exciting new paradigm that we might put in our toolbox in the future in screening patients for cancers. You've chosen a scenario exploring the assessment of Ellen, our 65-year-old patient who presents for a routine clinic visit. So let's take a look at how we might have proceeded with the clinical assessment of this patient who has some vague but not particularly threatening symptoms. Ellen is our 65-year-old patient, and she presents with occasional abdominal discomfort and constipation, but no other worrisome symptoms. She has a history of hormone replacement therapy post-menopause. She was a former smoker and has a total of 15 pack years in her history. During the evaluation, she's noticed 2 cases of breast cancer among her close relatives, an aunt and a sister that both happened over the age of 50. So you examine her, talk to her, and due to a lack of symptoms and clinical signs on physical exam, you recommend no further evaluation, some dietary changes, perhaps increase her fiber, increase her water intake, and follow back up with you. So, the pandemic's happened and we're not getting people back in all that often. And Ellen doesn't come back to see you for a year. Her abdominal pain has worsened and she's had a bunch of weight loss. On exam, she's got a very swollen abdomen and you note ascites on your physical exam. So based on these findings, you order a CT scan of her abdomen and pelvis. The findings show some ascites and you refer Ellen to an oncologist. So Ellen undergoes the standard assessment, including an abdominal pelvic exam, imaging, ultrasound and abdominal CT, a CBC, and a CA-125 assessment. The CT scan also showed an ovarian mass and a lesion in the peritoneum and several nearby lymph nodes. The pathologic evaluation confirms advanced disease, stage 3B ovarian cancer. Options are offered to Ellen that would include surgery and adjuvant chemotherapy. Ovarian cancer is also another cancer that causes death and currently has a lack of screening. There are over 21,000 new cases of ovarian cancer in the United States in 2021, leading to close to 14,000 deaths. Most cases, 90%, are epithelial ovarian cancer, the majority of which are high-grade serous tumors, which have the fewest risk factors and the worst prognosis. When we look at estimated deaths from ovarian cancer in the United States, it is the 5th most common cause of cancer death in women in the United States. So what are some of the risk factors for ovarian cancer? Advancing age, a strong family history of breast or ovarian cancer, certain inherited mutations, for example, BRCA1 or 2, or those related to Lynch syndrome, personal history of breast cancer, endometriosis, pelvic inflammatory disease, or tall adult height. Currently, there are no recommended screening tests. Pelvic exam in combination with transvaginal ultrasound and CA-125, which some people have talked about as a way to screen for ovarian cancer, is associated with a high prevalence of false positive results. And that association with false positive results could lead to a lot of hysterectomies done in women who do not necessarily need to have a hysterectomy. And what are some of the symptoms? Well, ovarian cancer signs and symptoms. Early ovarian cancer usually causes no obvious symptoms. However, some women might experience persistent, very nonspecific symptoms. Back pain, bloating, pelvic or abdominal pain, difficulty eating or feeling full quickly, urinary urgency or frequency. The most common sign of ovarian cancer is abdominal swelling caused by a fluid accumulation or ascites, and that usually occurs when cancer is advanced. So what are some of the current challenges for screening and detecting ovarian cancer? Well, again, blood testing is far more desirable and much more patient-centered than an ultrasound or CT scans. And transvaginal ultrasounds have internal probes, which certainly causes some discomfort, some immodesty, and is certainly not something that a lot of our female patients would be interested in being part of unless they really had to. Not every patient knows the BRCA status of family members with breast cancer histories. So one of the things, it might have been very obvious if she said, boy, the BRCA gene runs in my family. But a lot of people don't know that. And I think sometimes we overestimate how much history people are going to know about family members. It's hard to diagnose ovarian cancer based on signs and symptoms and physical exam. So we'd want a screening test that has good sensitivity and specificity. Improved screening definitely is needed for high-risk patients. And blood tests might be even helpful for those with a previous history of ovarian cancer, instead of completely following based on CT scans. And by the time you see something on a CT scan, something might have advanced further than you'd like it to be. You've now chosen to explore how multi-cancer blood-based screening might change how we assess patients with uncertain or nonspecific symptoms, such as the case of Ellen, who is our 65-year-old patient with occasional abdominal pain. So let's take a look at how this evaluation might have proceeded should blood-based screening become available. So Ellen is our 65-year-old patient, and she's presented with occasional abdominal discomfort, but no other worrisome symptoms. She has a history of hormone therapy postmenopause, and she was a former smoker. During the evaluation, she's noted 2 cases of breast cancer among her close relatives, an aunt and a sister, both over the age of 50. She has no other telling symptoms, but Ellen admits she feels anxious. There's cancer that runs in her family and her family history. So after discussion with Ellen, you recommend a cfDNA screening and explain that it's a blood test drawn at the lab. It can look for cancer and, if positive, can help point to likely cancer sources. Certainly, we're not going to take away some of the screening that she's doing. She's still going to need colonoscopy. She's still going to need mammograms, probably much more often with her family history for breast cancer screening. 65, she might be getting her last pap smear. So we're not going to replace the screening that we do. She wouldn't qualify for lung cancer screening with a 15 pack year history of tobacco. It can be helpful in screening for cancers that previously weren't screened for, such as ovarian cancer, and can lead to earlier detection that may be associated with better outcomes. So the blood plasma is taken and cfDNA screening is performed. The screen is positive and it suggests ovarian cancer. You refer Ellen to an oncologist, and she undergoes a standard assessment, including an abdominal pelvic exam, imaging, ultrasound and abdominal CT, CBC and CA-125. A mass is noted in both ovaries. Surgery is recommended with pathologic assessment confirming that she has an early stage cancer, a stage 1B. So what are some of the risk factors that we have for ovarian cancer? Age, a strong family history of breast or ovarian cancer, which certainly our patient has, certain inherited mutations, BRCA1 or 2 gene, or those related to Lynch syndrome, personal history of breast cancer, endometriosis, pelvic inflammatory disease, or tall adult height. Again, there is no recommended screening test. So pelvic exam in combination with transvaginal ultrasound and CA-125 has been associated with high prevalence of false positive tests. So in the CCGA study, stage 1 to 3 sensitivity was 67% in pre-specified set of 12 cancer types. And they included anus, bladder, colorectum, esophagus, head and neck, liver, bile duct, lung, lymphoma, ovary, as our patient will turn out to have, pancreas, plasma cell neoplasm, stomach, and overall, these cancers account for 63% of US cancer deaths. So the validation study, if she had something that was pointing towards her ovary, in this particular finding, 100% really pointing towards the ovary in the validation study in this particular study by Dr. Liu. So what screening for ovarian cancer might look like with blood-based tests? Well, ovarian cancer is often found in an advanced stage. 95% of deaths from ovarian cancer in the United States are in those over the age of 45. So certainly we might have some areas that we think guideline-wise who we might start thinking about this in. The symptoms are very nonspecific, and probably, every day in our office, we have a couple people who potentially could have symptoms that we could put in the ovarian cancer bucket. The United States Preventative Task Force gives current screening for ovarian cancer a D recommendation. And even in higher risk women, there's not been a whole lot of yield on screening modalities available in decreasing mortality. The availability of cfDNA screening could potentially change this paradigm, as illustrated in Ellen's case. The applicability of the test needs to be defined. For example, is this a test we're going to just use, like in Ellen, as a diagnostic test, or are we going to use it as a screening test? If we're going to consider using it as a screening test, do we screen all women or those just with risk factors? What age would we start? How often would we screen? So certainly there are a multitude of questions that ultimately might need to be answered. But it would be great to be in our offices and be able to screen for some of these cancers that we currently don't screen for, and not have to look at families and say, I'm sorry you have this cancer. It's a common cancer, but it's one we don't look for. Thanks for joining me.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/KXM860. This activity is supported by an educational grant from Grail Incorporated.